I would love to welcome our four presenters. Each of our presenters have had a key role in responding to Hurricane Katrina in the past 10 years. Our first presenter is Dr. Anthony Spire. Dr. Spire is currently a clinical associate professor of psychiatry at LSU Health Sciences Center. Following Hurricane Katrina, Dr. Spire served as the director of the Louisiana Spirit Hurricane Recovery Program with the Louisiana Department of Health and Hospitals Office of Mental Health. There he directed the statewide $100 million crisis recovery program, assisting displaced families and individuals returning to housing of their choice and other recovery-related programs in Louisiana. Our second speaker is Dr. Howard Osofsky. Dr. Osofsky is the Kathleen and John Bricker Chair at Department of Psychiatry at LSU Health Sciences Center. He was also the co-director of our Louisiana Rural Trauma Services Center, which is one of our centers at the National Center for Child Traumatic Stress. Dr. Osofsky will share the key roles he has played in New Orleans, the surrounding areas, and throughout the state as it relates to Hurricane Katrina recovery efforts. He has also been a leading expert nationally and internationally after numerous disasters and mass violent events. Our third presenter is Ms. Michelle Manny. Ms. Manny is currently the Chief Section of Social Work and Assistant Professor with the LSU Health Sciences Center in the Department of Psychiatry. Ms. Manny was the coordinator for the LSU First Responder Support Program in the aftermath of Hurricane Katrina. And finally, Dr. Joy Osofsky. Dr. Joy Osofsky is a clinical and developmental psychologist and the Paul J. Ramsey Chair and Professor of Pediatrics and Psychiatry at LSU Health Sciences Center. She was co-director with Dr. Howard Osofsky of the Louisiana Rural Trauma Services Center within our network during Hurricane Katrina and for 6 years after during the recovery period. Dr. Osofsky will also share the key roles she's played within her community and across the state as it relates to the recovery efforts after Hurricane Katrina. Before we begin, I'd like to turn it over to Dr. Robert Pinus to say a few words.
Thank you, Dr. Breimer. This series of webinars is an extremely important one for the National Child Traumatic Stress Network. Katrina was an extraordinarily catastrophic hurricane that landing on Mississippi covered a wide region, and with the secondary consequences from the levees break, with an enormous loss of life threat and enormous loss of life, over 1,500, with one of the largest populations to be displaced in the history of any major storm to land in the United States, and with its effects on not only civilians but 4 military bases that had to be evacuated in the early time period. It has obviously been very much a part of the national discussion and the national challenges for many years now. It also is extremely important in terms of the National Child Traumatic Stress Network. Upwards of 22 states where people were displaced, including 32 network centers and 32 partners, contributed to years of response to Katrina. So this has had a very central place in our network activities, our network partnerships, and our extensive work within schools, within the disaster response of states, as well as the federal government. And lastly, we have 4 presenters today to which I think all of us need to keep in mind the enormous, certainly, admiration and respect that I have for their perseverance, for their tireless work. This is called innovation and legacy. Well, they certainly have been at the heart of innovation, the heart of legacy, but the innovative activities that you can hear about today, even starting in the earliest hours, have led the way to the long-term trust and resources that could really contribute to the recovery of this region. And we're really privileged to have them as our initial webinar. But we're going to also hear from others through the next webinars who also have had their contributions, to which I think our network owes a debt of gratitude as well. So with that, we'll get started.
So, Tony, we're going to turn it over to you.
Thank you, Melissa. Thank you, Bob, for the kind words. I want to begin with a brief description of what we found ourselves facing. An important aspect to kick off these webinars is to revisit the scope of Hurricane Katrina as a catastrophic event. Prior to going through that process, I need, as an individual and also as a representative of our state, to thank the nation, all the nation, and the many partners in the world who provided such assistance to us in those very difficult times. And it will be something I know none of us in Louisiana will ever forget. Specifically, I'd like to thank what we called our practice directorate, which you'll hear a little more about in a few minutes, which consisted of my colleagues, Howard and Joy Osofsky, Dr. Tanya Hansel at LSU, and then Bob Finus and Melissa and Breimer and Alan Steinberg and Betty Pfefferbaum from the network. And then from the National Center for PTSD, Joe Ruzek and Patricia Watson. Without their guidance and leadership in helping bring national models for us to use and adapt in a way that was most appropriate for people in Louisiana, we would not have experienced the successes we had. And finally, Charlie Cook, who was a former project officer with SAMHSA and a co-director with me of the Louisiana Spirit Program. His efforts were tremendous in making this happen, and our project officer from SAMHSA, Linda Laginza, who's now at the National Council. So with that, I'll jump right in here. Okay, if you can put yourself in the place of Monday, August 29th at 4 a.m. in the morning, you would start to feel the bands of Hurricane Katrina coming across the shore at 6 a.m. making landfall with speeds of up to 140 miles per hour. And let me stop there for a minute to let our slide people know I'm on slide 3. Hurricane Katrina makes landfall. Storm surge is up to 22 feet in New Orleans, which was one problem, the next being that the levees started to break. And what we call the 17th Street Canal started flooding, which is in relationship to Lake Pontchartrain. Within a matter of hours, 80% of the city of New Orleans was flooded. Next slide, please. Hurricane Katrina ended up with a loss of life in Louisiana of 1,577 people. Many of those who stayed behind took refuge on their rooftops, not realizing they were going to be in for 15 feet worth of water flooding, and had to be rescued from their rooftops. The Coast Guard jumped in right away and were essential for many lives being saved. The Superdome, Louisiana Superdome, ended up being a shelter of last resort, which was quickly, after 3 days, closed, and people evacuated to the Astrodome in Houston. Superdome lost all power, all plumbing, all water. It was not a pleasant place. Next slide, please. You're now experiencing into up to September 5th, no clean water or electricity in New Orleans. The city's continuing to be completely evacuated. There are no communication mechanisms. All cell phones do not work. The U.S. military is finally showing up with ships and helicopters. We have ships offshore for hospital ships, as well as other personnel carriers to move people to other parts of the country. FEMA begins search and rescue operations, looking for people who had drowned in the storms and had other kinds of difficulties getting rescued. And people are then beginning to be moved to hospitals. They're being set up in various parts of the Louisiana non-affected parishes. Next slide, please. All in all, 1.7 million people lost power. And in August in Louisiana, without power, puts you in a very fragile state. You can imagine all the people who are ventilatorless and electrically dependent on electricity for their survival. not being able to have access is very frightening. Most of the highways are closed, so there are no transportation routes available to the general public in or out. And after another probably 18 hours, Katrina moved across the states above Alabama and Mississippi into Tennessee, Ohio, and Georgia, where I think there were a total of 51 tornadoes associated with the path that Katrina followed. Next slide, please. Just really talk about Louisiana and the impact on our rural areas and the impact on New Orleans. But it's good to remember that Bay St. Louis, Pass Christian, and Waveland, Mississippi were really areas that took the brunt of the storm surge, and those small towns along the coast were virtually wiped out. And many have recovered, and recovery continues to be a big struggle. Can you imagine a storm surge of 28 feet and sea waves up to 50 feet? Quite terrifying, and because of a lot of the evacuation, that while they had 235 persons lose their lives, loss of life would have been much greater without their evacuation. About 1 million people in Mississippi were affected. The damage to the 4 military bases is over $1 billion, and many historic landmarks along the Biloxi and Gulfport coastline were destroyed. 2 people in Alabama also lost their lives, with Mobile Bay being flooding Mobile, the city, and Bayou La Batre, a small fishing town, being just about totally destroyed. Florida got touched by Katrina twice, once before it came to Louisiana and once after it left Louisiana, and unfortunately experienced 14 deaths. Next slide, we're looking at an interchange of the Cloverleaf in New Orleans just hours after landfall. That's how quickly the water moved in from the breaches on several major levees and the overtopping. If you turn to the next slide, please, you'll see some people who didn't expect to be evacuating, walking through the water, trying to find a safe shelter. Next slide, please. You'll see the Superdome, which as a shelter of last resort, had people just showing up with the clothes on their back and hoping for a safe place to stay. All these people had to be evacuated. We did, very fortunately, next slide, please, have the experience of a simulated evacuation in a project called Hurricane Pam just a few days before this catastrophe of Katrina hit. And the idea of getting people out of the flooded New Orleans was developed in that process. The first location was called a lily pad, people in the height of danger where they were and needed to be extracted from. They were then taken to search and rescue base of operations, referred to as SARBOs, on the next slide. And you'll see some buses, many people outside. That's the middle of an interstate highway that is our definition of safe refuge at that point. And then the temporary medical site is actually the New Orleans airport, where many people were taken from exhaustion and other kinds of situations they had. The next slide, please. You'll see the LSU basketball arena as a better organized temporary medical assistance center. This was put together as the main location. About 44,000 people were triaged in that facility in the few days after the Katrina hit. So we've got everybody evacuated now. We're in the process of it. If you're staying with me on my timeline, next slide, please. And you'll see some of the immediate issues that were coming up. We had pharmaceutical issues. We had the recovery of bodies, identification of bodies, mental health issues growing at a very rapid rate, many environmental issues starting to emerge, major immunizations for evacuees, and surveillance for disease in shelters, hospitals, and first responder locations, and then the urgent primary care that was necessary for evacuees, as well as now having to deal with the health of personnel who were trying to work heroic hours, 72-hour shifts at a time without sleep. In the general shelters, next slide please, you'll see a picture of a general shelter in Lafayette, Louisiana, where just cot after cot after cot, massive amounts of bedding for people, where as of September 5th, there were 50,000 people housed in 152 general shelters just in Louisiana, with 9 shelters having more than 1,000 people in them. And the reports on the amount of sanitary conditions available, bathrooms, and needs for people who had adaptive needs, we weren't prepared for, and it was not a good situation. We did lose, next slide please, we lost a number of Louisianians and developed what was called the Louisiana Family Assistance Center. With the help of our colleagues in the Red Cross from New York, who had worked with the 9/11 Family Assistance Center, this program was set up, and next slide please, as with a core mission, and I'll quote here, to help frightened and grieving families find out what happened to those they loved who were missing as a result of the hurricanes and Katrina and Rita. Main mission was being 4 points: reunify loved ones with the victims of Hurricanes Katrina and Rita, assist in the identification of the missing, support the reinterment of the displaced victims from public cemeteries, and using the information in a confidential way only for the purposes of reuniting families with the victims of the storm. There were 13,197 missing person reports filed, and the major sources of death were drowning, 40%, injury and trauma, 25%, and heart conditions, 11%, with a high percentage of people being elderly who died. The Family Assistance Center was, next slide please, was a tremendous place of compassion, being staffed by volunteer chaplains, taking the calls all coming in, and you'll see from this little vignette from a woman who was searching for her family members, of her genuine gratitude for the compassion people provided. This was a really great service offered and was so meaningful for so many people. The next slide, please. I won't go through it in detail, but it just shows the locations, the number of locations where the Office of Mental Health had to assign professional staff. Next slide, please. You'll see that because of the catastrophic nature of this storm, the additional load that was put on beyond where we already were. So we had to institute additional mobile crisis teams. We had to staff the Family Assistance Center. We had to provide the ability to handle the infusion of more people into hospital operations and clinics, as well as provide stress management to the staff. The point of these 2 slides is just to point out that no matter how prepared you are, there's going to be many, many things happen that you can't anticipate. As you, next slide please, as you go into long-term recovery, you need to start thinking about how can you rebuild your communities. What's happened here is not just an injury to a community, but the total devastation of a community to where you now have the disintegration of order, the need to reestablish order, and the need to build a long-term recovery process. The model for doing that is the Louisiana Spirit Hurricane Recovery that has 4 basic goals: integrate with other recovery initiatives, innovate national strategies that have worked as evidence-based services for children and adults in other areas into Louisiana, assist communities as they dynamically evolve through the recovery process, and provide services through highly localized networks. Next slide, please. You'll see on this slide, I'll let you just look at it with your own convenience, the number of different entities we had as segments of Louisiana Spirit. The idea being to specialize in providing services to persons most at risk but organizing services in such a way that communities develop their own response and that we were assisting them in their own recovery, not trying to direct their recovery. Next slide, please. You'll see the range of different types of organizations. It's essential you get partnered with immediately, because these are the partners that result in building the emerging resilience that will get people through long-term recovery. Next slide, please. You'll see just the four basic components of how we organize the delivery of care. And I'm going to stop at that point, because I think the last slides or items that just show the some of the media activities we used during the Louisiana Spirit long-term approach, leaving you with the saying on our last slide, hope is an enemy of despair. If you think you've lost yours, call us. That was very comforting to many people. Howard?
I want to thank all of you, and I particularly want to thank Bob and Melissa for the roles they played and for inviting us to this presentation. You can see in slide 2 a picture, one of the many pictures of the devastation. In slide 3, I want to describe just a number of roles that I played. I was called back. I was actually consulting for some of the NCTSN centers in New York on disasters when our Hurricane Katrina hit, and was called back immediately, also by the head of the crisis response center, the control center, the head of the National Guard and state police, and Joy and I were flown immediately back to be in Baton Rouge and work with all of the programs. Within the limits of the Stafford Act, we tried to, which prohibits mental health services in the crisis response roles, we met crucial crisis response needs and focusing on recovery and rebuilding right from the beginning of our role. We recognize the enormity of the resources needed for short and longer term recovery. We recognize that recovery from a disaster, a major disaster of this proportion, requires 5 to 10 years, not the usual 3-year scopes that are provided. We found it important to respond to the enormity of loss, displacements, unknown fate of family and kin, to support the heroic efforts of the first responders and their courage under very difficult circumstances, including what they felt was their inability to totally protect the community. We tried to provide volunteers with 2-week efforts, knowledge of the living conditions, which is very important, and of the cultures, and of the need to support the local structure, which would be providing the services over a period of time. In my role, was also to recognize the stresses on providers who were themselves survivors with secondary traumatic stress or with just the traumatic stress they were experiencing. For example, in emergency rooms, how difficult it was for people to deal with patients with mental health complaints and stresses when they themselves were living with their own stresses. The provision of medical student education and training for psychiatrists, psychologists, and social workers, and above all, the provision of patient care. In slide 4 is just a picture of the Superdome and of people who are flocking to the Superdome, trying to get some type of shelter. In slide 5, I described some of the efforts in rebuilding the Department of Psychiatry. There was absolute loss of facilities, including the loss of the medical school, the loss of Charity Hospital, the loss of New Orleans Adolescent Hospital, the loss of what could be used for medical student education and for training. Patients and staff were transferred to other sites, And often our faculty accompany the patients who are being transferred. For example, the adolescent patients from New Orleans Adolescent Hospital, our chief of child psychiatry and residents went right with them. Or people being transferred from Charity Hospital, the courageous Rome. The limited contact with faculty and staff due to lack of internet, telephone, and cell service. We had to provide training at sites throughout the state and educational facilities relocated to Baton Rouge. For example, there was one office where the chancellor was able to share office space with the president of the university. And then at the Pennington Center, where they provided us with some offices and conference rooms, and then the Human Service District, where we would do telepsychiatry weekly conferences for residents who were scattered in other sites, but who could phone in or do it via their computers. We were required to provide faculty furloughs. LSU HSC had to declare a force majeure as it ran out of money to pay faculty. And all part-time faculty were furloughed, as well as those whose salary couldn't be covered. Many of us have stayed around to rejoin us. Emphasis placed on ways to work with patients impacted by Hurricane Katrina and building resilience. I want to note that few residents left the department. And even though we had to suspend recruitment for a year of psychology interns and cut our resident class to 6, given the limited number of sites, we filled in all areas: child psychiatry, adult psychiatry, and psychology. I'd like to switch in slide 6 to the first responder service. On the second day, the mayor, the New Orleans Police Department, the New Orleans Fire Department, and State Police requested services from me and the department. The mayor actually got on television and asked, could I provide the services for first responders? We placed emphasis on psychological first aid, as is developed by Melissa and NCTSN. Services were provided in the first responder temporary locations, which would shift all the time. And one would have to pass through security checks. One had people with guns, where we had to show that we were the people who were supposed to be there. Joy and I climbed up the 9 floors to where the heads of security were stationed at City Hall with no air conditioning in the building. We lived on the boats that were provided. Michelle Maney will describe that, to bring first responder families back to first responders. But Julia Street Harbor, we worked with the firefighters who are housed in a temporary location, and with the first responders in St. Bernard Parish, who were in another boat, but where no families could come back. We worked out in the fields and had services actually literally in the field with first responders. They had to deal with loss of homes, displaced family members, economic hardship, and concerns about meeting the responsibilities, which they were meeting heroically, but of course couldn't meet all responsibilities. We also helped non-traditional first responders, teachers, nurses, bus drivers, and other support staff. For example, Joy and I had a group with some of the heroic nurses at Memorial Hospital who were in charge of the neonatal program, got the babies out safely, but then stayed to try and help with the other people who were trapped in the hospital and didn't know if they could go back to nursing ever again. But as we worked with them, they realized their courage and their strength and their ability to return. Slides 7 and 8 show pictures of first responders and during some of their heroic rescue efforts. I want to just share the first responder statistics on page 9, on slide 9. When we did it, and we did very careful surveys using the CES, the Center for Epidemiological Studies, measures of depression, and the post-traumatic scale civilian version and do the most conservative estimates, and I know people around the country who were also experts said it mirrored what they found. 10% met the cutoff for post-traumatic stress disorder, but 20 to 30% endured significant symptoms of PTSD while not meeting full criteria for diagnosis of re-experience and avoiding and hyperarousal. What was interesting is that more met the criteria, the cutoff criteria for depression, and that was true not only at 6 months when we did this, but at the end of the first year when we repeated these measures, both of them remained consistent. More than 40% reported an increase in either frequency, amount of alcohol consumption post-hurricane, and at times it being very problematic. 40% also reported an increase in conflict with their partners. Upwards of 48%, and this again came up, which defies traditional myths, reported they were interested in further mental health services for themselves and their families. And as I mentioned, this was true after a year as well. The PowerPoint slides 10 and 11 show other heroic first responder rescue efforts, as they described what they were doing, including having to move dead bodies or somehow getting people trapped in attics or on rooftops and doing the very best they could. In PowerPoint slide 12, I described the resilience, the strengths of the community that could not have been recognized before Katrina. We emphasized both strengths and resilience in our first responder work and our work throughout the state. We also were able to identify the return to early work is a path to recovery, not just a response to disaster, but really helps people in their coping and resilience. Joy will later talk about the children and the remarkable resilience. In community surveys that we did over a period of years too, and then in 2012 after the oil spill, over 90% of Southeastern respondents reported that even if they had symptoms and adversity and economic adversity, they could overcome adversity and bounce back from difficulties. And we were able, with them, to recognize post-traumatic growth and new strengths that people develop, new strengths, inner strengths that they could utilize to be helpful. I would just like to then talk about lessons learned. Some of the lessons that we learned were the need to have preparation to respond to disasters and address immediate and long-term needs right from the beginning. And our state is so much better equipped to be able to do that at this point, as well as schools, communities, and clinics. The preparation of facilities that will receive individuals, especially those with special needs, and especially children, reunite with families and the elderly, the special needs that they have. There was a disproportionate number of deaths among the elderly following Hurricane Katrina. And people who no longer have the supports of families and of kin. The need to train mental health professionals to meet special needs. And that's important throughout the country. And I know that NCPSN, the Red Cross, we have all been involved with that and dealing with that. The need to deal with providers who have losses, including the many types of providers who themselves have had, within their family, losses of jobs, homes, friends and family members, or displaced families. The need to apply professional skills in previously unanticipated ways. One is not going to be effective sitting in offices at that point. One has to be able to work in the streets, to work in shelters, to work where people are and helping them. The importance of dealing with compassion fatigue and secondary traumatic stress, which is crucially important, and giving people some time off, letting them be able to talk with people. And the focus on resilience of individuals, families, and dedication to communities, which people do have, and the post-traumatic growth. I'm just going to conclude giving you a telephone number that we have for a crisis hotline that we staff 24/7. It's always staffed by members of our department with the availability of professionals in each of the specialties, and also the ability to refer to other resources, the ability to get people when they need further evaluation and treatment. And that is 504-288-6196. And I thank you very much, and I thank everyone who has been so important in providing the efforts.
Michelle?
Yes, hello. Thank you so much, Robert, for introducing us so nicely, and Howard and Tony for setting the stage so beautifully. I'm going to talk a little bit about our first responder support program, the work we did on the cruise ships. As Tony and Howard both described, about 80% of the Orleans Parish was flooded, and most of the first responders' homes were either damaged very badly or destroyed completely. 2 Carnival cruise ships were donated to house the city workers, and those were brought to dockside near downtown New Orleans at what's called the Julia Street Wharf. At that time, the first responders were working 7 days a week and were working 12-hour shifts. Next slide. So you will see some images of the destruction at the time. Was very severe. There was a lot of recovery work still going on. Many streets were not passable. There was really no electricity for much of the city. There was still body recovery going on for a long time, for many, many weeks after the storm. Next slide. So if you can go to the slide that says first contacts. The first contacts that we made were Howard, Joy, and Tony meeting with the police chief, the fire superintendent, head of EMS, and the mayor in order to get permissions for us to work directly with the first responders. And one of the exceptions that we requested and was so important in terms of the kind of work and the quality of work we could do was to get the permission to do the work with full confidentiality. And this is something that had not really been given before, but due to the nature of the disaster, fortunately, the heads of these departments were willing to allow us that. And we felt that it would ensure that the first responders would be more likely to reach out to us and to utilize our services. And in fact, that proved to be the case. So the services that we provided were in no way accessible to higher-ups. We were never asked to report back on who we were seeing or what we were seeing them for. We were never asked to do fit-for-duty evaluations. That was given to people within the department to do. And so our role was very clear, and we maintained very clear boundaries in order to assure that the first responders maintained confidence in their ability to access services in a private way. The second level of contact was meetings we had dockside. We went to the dockside near the ships because at that point you needed special permissions to be on board the ships. And we met with first responders as they came off the ships and went back on after their shifts, and just asked them, how things were going and what services they felt would be most useful to them. And basically identified, I'm sure as most of us would have thought, Maslow's hierarchy of needs was really the reference point, that the basic needs of safety came first, then connection with social supports. And so we began to develop some plan for how we would help to meet those needs. We needed to obviously to provide confidential, stable mental health to providers. Provide confidential, stable mental health services to the first responders and to reconnect them with their families. We did, as Howard talked about, implement a formal needs assessment while we were on board the ships. We did get permission from FEMA, Homeland Security, and the dock, the Port of New Orleans, to be housed on the ship. So Howard and Joy were housed on the ship, and I was also housed on the ship in order to oversee that program and to begin to coordinate. In discussions with the first responders that were already on board the ships, we knew that the main reason why they did not have their families with them was their concern that their children would have nowhere to go to school. And so Joy immediately got to work coordinating with the Department of Education to see if we could not arrange for schools to be receiving schools for our first responders, and we'll talk about that a little more. But there was certainly a recognition immediately of the need for an acute response in order to stabilize the first responders, to provide them with needed acute mental health care, and also to look at the long-term needs that would be taking place. Next slide. One of the first services we put in place, and this is very consistent with the implementation of psychological first aid, the principle of utilizing mental health services that don't initially look like mental health services. We put together a daycare that was open 2 hours a day, 5 days a week, for the younger children, because what we found was there were many first responders and who had actually been able to bring their spouses to live with them on the ships with their young children, and the spouses were exhausted because they'd had these young children in their 24-hour care for weeks. And so this daycare provided them some time to rest, to apply for loans if that was needed, or just to have some quiet time. We also put together activity for school-aged children and teens. We put together family talent nights to draw people out of their rooms and to get them to socialize more, to reduce isolation, which was beginning to take place at that time. There was informal mental health support that we provided on the Lido deck, which was sort of the deck on which there was the cafeteria where the Carnival cruise chefs served 3 meals a day, but also the outside deck where people tended to go outside to smoke or to just relax and sort of get some private time. And we would just sit with people and chat with them and, apply what we call the 3 magic questions. How is your family? How is your house? And do you have any pets? And by asking these 3 questions, we usually generated a nice conversation that would lead to enough information to assess what needs we might be able to provide for them. We would also meet with them during meals, just informally, go to their tables, see how they were doing. We would go on ride-alongs with first responders and were going to their work sites regularly to check in with them there. And we did practice a good bit of self-monitoring by the LSU staff to ensure that we were implementing appropriate self-care practices so that we were able to be accessible to the first responders for as much time as possible at the highest quality of service provision as possible. I want to point out here that many New Orleanians do not know how to swim despite being surrounded by bodies of water. And one of the things that we became acutely aware of was that in the interim between Hurricanes Katrina and Rita, many of the first responders had been brought on board the ships. When Hurricane Rita was headed towards Louisiana, Carnival decided to bring the ships out to the Gulf. And so many first responders were taken on that trip out into the Gulf and found themselves in 30 to 40-foot seas, which was terrifying to them because, as I say, many of them did not know how to swim. And so there was a lot of nervousness about whether they would have to put out to the Gulf again in case there was another storm. And we did have one incident where one of the ships actually broke loose from the pier and drifted out into the river. Fortunately, it was captured by one of the tugboats and brought back. But these incidents obviously escalated some of the anxiety people were already feeling. Next slide. This is a view of the breach site of the Industrial Canal breach at about 5 weeks after the storm. This is my very poor quality panoramic that I put together when I visited there. Next slide. Again, with a view to the principles of psychological first aid, we looked to empowering the survivors as much as possible. Halloween was the first holiday after the storm that the families could participate in. We were getting some families back because the schools were now receiving first responder children, and the first responders felt it was good to bring them back at that point. And so we began discussions with the first responders about perhaps putting on a little Halloween celebration for the children. They were extremely excited about this and really wanted to do it themselves. And so they planned the party and bought the supplies, bought the candy for little trick-or-treat tables. We knew that the first responders were still on 12-hour shifts 7 days a week, and so we didn't want to go door-to-door for the trick-or-treat. So we had trick-or-treat tables on the Lido deck and had a little party out on the Lido deck. And the children were encouraged to mask. And the next few slides are going to be pictures of that party. So the next slide is a picture of some of the police officers setting up the deck on the ecstasy where they were housed. The next slide is a picture of one of our faculty, again doing something that is not traditionally considered a mental health activity, but certainly served the mental health as a mental health support to these children. The next slide was one of our little children that was on board who was just adorable, and everybody warmed up to immediately, but he came as Superman. The next slide, another young boy who was participating in a make a mummy race. Next slide, a little child participating in one of the trick-or-treat tables that were present on the deck. The parents were given throwaway cameras by LSU, which were then collected. Their names were put on the cameras, and we were able to develop the pictures and give them back to them, so they were able to document this first holiday together. And we felt, again, while that was not a traditional mental health practice, it certainly helped the families to share a holiday and share a happy memory among what was really a very chaotic time. Next slide. At about 3 months out, our focus began shifting to helping the first responders navigate the holiday season, where they had started off feeling a great deal of anxiety and hyperarousal and difficulty sleeping when we were first working with them as we boarded the ships. Now, at 3 months out, nearing Christmas, nearing Thanksgiving, they were beginning to shift more to depressive symptoms and more isolation. The long months of 7-day weeks and 12-hour shifts were really beginning to turn into real exhaustion and irritability. And the strength that we found was that these ships were really becoming kind of small communities amongst themselves. And we noticed that coming on board the ships, we were actually able to recognize each other. We did not always know the names because there were up to 2,000 or more people on each ship, but you got to where you recognized everybody who belonged on the ship and who were visitors. And so it really became like a neighborhood unto itself, and we felt that that was a very protective factor and reduced isolation, which could have happened if people had not been together in these communities. One of the things we had instituted in order to provide more stability to the first responders was that previously SAMHSA volunteers had been coming in on 2-week rotations and had been providing mental health services. And this had been experienced as, in some ways, destabilizing and re-traumatizing to our first responders, because they would begin to share with this individual and then they would be gone. And so we decided that one of the ways that we would help to support recovery would be to assign a specific clinician to each district house or each station house, and specific group of clinicians to each ship, so that it was always the same group or the same individual clinician that was seen at a specific site. And we made a commitment to be present at those sites over the long haul. And this, I think, did contribute a great deal to the first responders developing trust that we would be there for them for the long term and not just the short term, and again allowed them to open up to us a bit more. Next slide. This is some view of this on the way to one of the district houses, even that many months out, even just minor repairs of just getting things boarded up still wasn't necessarily happening. Next slide. But again, the wonderful crew on board the ships did these wonderful gestures for us. There was this gingerbread New Orleans village that was done by the cruise ship chefs. Difficult to see in this photograph, but there's a little NOPD headquarter and a fire headquarter in there, and the Carnival, one of the cruise ships, is visible on the little river there, and so it was very touching that they did that gesture. Next. As you see in the streets, it was a little more dismal. There was, I think, still an effort made to recognize that it was a holiday season, but in the midst of still great chaos. Next slide. LSU and SAMHSA worked together to coordinate a toy giveaway for the first responders' children. So one of the SAMHSA volunteers dressed up as Santa Claus, and the first responders were able to bring their children to have a Christmas present from Santa and have their picture taken with Santa. And this was very appreciated by the first responders. Next. This is a Christmas village that is traditionally at our local mall, and on this particular holiday season, you can see that the village was somewhat changed. There are blue tarps and workers on the roof. Not visible in this particular slide is a helicopter actually rescuing someone off a roof, which was also present as part of that village. And so you can see that the sense of the chaos of what we had been through was still permeating even these holiday celebrations. We were still coming to grips with those feelings. Next slide. So as we approach New Year's, we began to help the first responders plan for transitioning off the ships in February when they would be pulled out of New Orleans. There was linkage with resources for those encountering obstacles, formal treatment, shifting to clinics as they opened. And then, because we recognized that the ships had been communities for the first responders, we also recognized that leaving these communities involved a grief process of its own. And so we wanted to very much address that grief process, name it, and help the first responders plan for what kind of communities they were developing in the areas they were going to be moving to, whether it was into a FEMA trailer at their house or if they had found other housing somewhere else, but trying to identify that community that they could reach out to. Additionally, we continued to offer services in clinics as they were opening up, and transitioning those first responders for whom we were providing mental health services, more formal mental health services, to those clinic services. We continued to go out to their work sites and provide informal mental health support. And indeed, I take it as a mark of the success of these efforts that At those times where we unfortunately had the deaths of two police officers, I'm remembering in particular. One was killed by someone she was attempting to apprehend. Another one was killed in a robbery of his home. We were called out immediately to the site to provide support to the other first responders there. And I think that speaks to the level of trust that they had developed, that they could come to us and we would give them support, and it would be kept private. Thank you for your time.
Thank you very much, Michelle. And for the audience, children and families are really, really important. They're important to all of our work, and they're obviously important to NCTSN. Without the help of Bob Heinus and Melissa Breimer after the storm, after Hurricane Katrina, I'm not actually sure how we could have moved forward that effectively. We've heard about all of the things that we did, but we didn't have any materials. We didn't have offices. We didn't have any of our materials. We didn't have all of the manuals we needed and anything like that. And so we would talk every day to usually Bob and Melissa from what Melissa warmly called it our car office. It actually was our rental car office in order to be able to adequately do our work. And for that, we're really so incredibly grateful. They've always been available to us, and it's made a huge difference. And anybody with a disaster, who's experienced a disaster, I'm sure a lot of you listening have gone through disasters. The support of NCTSN and our colleagues is just remarkable. So I'm going to talk a little bit about the children, and if we turn to the slide after my introductory slide, slide 2, everybody knows, I don't have to repeat, that the evacuation and rescue, children and families, was very poorly planned, very slow to help the city and the people, desperately trying to save lives and not separate children and families. But realistically, 189,000 children in Louisiana were displaced following Hurricane Katrina and Rita. And we came to understand, by the way, why some children and families were separated. You know, if you're on a rooftop and a helicopter comes and you have 3 children, you're going to put your children on that helicopter. Why they were separated on buses was poor planning and chaos, and we know that. If we turn to slide 3, the next slide, it shows where the families went, and you can see they went to many, many cities around the country. The red are the heavily impacted areas. If we turn to slide 4, and we're focusing on children, so the red areas are the heavily impacted areas, and we can see the percentage decrease in public school enrollment in the heavily impacted areas as compared with the blue areas, which were the receiving areas, where the percentage increase, there was a strong percentage increase. And actually, we're going to be talking more on the next webinar on September 9th about the declared areas and the undeclared areas, which is what this slide is referring to, but it's also very relevant to what we'll talk about in the children and families. So Michelle talked about the boat, the ecstasy and the sensation, and we felt that it was very, very important on the boat to have children and families, because first responders, city workers all had to be there to do their work, and yet families were separated. And so we talked to NOPD and the Coast Guard and FEMA about having the children on the boat, and Michelle has talked about the children. We didn't think ahead that much, though, the fact that we were going to have so many children come back to New Orleans with schools not open throughout New Orleans. It was going to be challenging. So we called on our relationships that we had, obviously with the Office of Mental Health. We've obviously worked closely with Tony Spire and others in the Office of Mental Health, but we also worked closely with the State Department of Education. They actually gave us additional office space and were kind enough to accept all the toys that were sent for the children from Sesame Street, boxes and boxes of Sesame Street toys. And between collaboration with the State Department of Education, Office of Mental Health, which it was then, NOPD, FEMA, Coast Guard, We actually were able to arrange, by talking with principals in schools in neighboring parishes just outside of New Orleans, and then the few schools that were open in parts of New Orleans that weren't heavily hit, to take the children into schools. And I'll never forget that morning on the dock when the school bus showed up to pick up the children and take them to school, and the police officers standing out there awestruck so that their children were able to go to school. That's helping the children of first responders and others get to school. But what about the children in the heavily impacted parishes where schools were destroyed? We're going to talk about one parish, they're parishes down here, not counties, where all of the schools were destroyed, and also we're going to talk about the role of mental health in the school. So if we turn to the next slide, we see what St. Bernard Parish looked like following Hurricane Katrina. All of the schools in St. Bernard Parish were destroyed by Hurricane Katrina. It sits right next to the lower 9th Ward, which people are a bit more familiar with, where, of course, everything was destroyed as well. And if we go to the next slide, we'll look, it's a picture of Plaquemines Parish after the storm, and all the schools in Plaquemines were flooded out as well. If we look at the next slide, we see what St. Bernard Parish looked like 3 years after Hurricane Katrina, where they were just thinking about building a Walmart, and there was nothing there at all. But the superintendent of St. Bernard Parish and the assistant superintendent, all the people there, felt that they could not rebuild their community if they couldn't open the schools. It was crucial to open the schools. And so you see on slide 9, I just have a heading, what the school looked like in St. Bernard Parish in 2005-2006. And in November, if you go to the next slide, in November of 2005, 3 months or even less than 3 months after Katrina, they opened the school with about 365 children in this makeshift area. So in St. Bernard Parish, the high school was the only school left standing, and it was all flooded on the main level, but the top level was okay, and they attached all these temporary structures and pulled together that school so that they were able to start. And there was actually a story that was told about a week after the school opened that I should mention that all of the children and families that were in St. Bernard were living in trailers, including the school principals, including the teachers. Everybody was living in trailers at that time. And they didn't have regular food, and they also felt that the children needed regular food. And so one day they carted in all of this meatballs and spaghetti in these big containers and served the children, and the children said to them, they said, we have real food. So this is amazing what they were able to do. I do want to tell a short story about mental health in the schools. So we started talking with the superintendent and other administrators of the assistant superintendent and other administrators of the schools right after, when we went over to St. Bernard, put our boots on, went through the muck, and talked with them about, did they need some mental health support when they opened the school? And they said, in general, we want to open our school. We don't need mental health. We just want to open our school. And so we kept talking to them and said, well, is it okay with you if we're there the first day when you open the school? They said, you can be there, but we really don't need mental health. And after 1/2 hour, they came over to us and they said, we know why you're here. Every child, adult, parent that walks in the school needs somebody to talk to. So that was the beginning of a relationship that's been a very long-standing and strong relationship with the schools in St. Bernard Parish and Plaquemines Parish and other heavily impacted parishes, and as we'll talk about next time, some of the parishes that were receiving some of the children as well. If we go to the next slide, I wanted to acknowledge, Melissa had mentioned in the introduction in the beginning, Louisiana Rural Trauma Services Center. Since 2005, we have been involved in Katrina work through our center that we were able to continue after 2011 with the Mental Behavioral Health Capacity Project. And using a modification of the NCTSN Hurricane Assessment and Referral Tool that we've actually modified a few times since it was developed earlier. We've administered to over 50,000 children between 2005 and 2015. And based on the screener, depending on whether children met the cutoff for showing either post-traumatic stress symptoms or depression symptoms, they were offered services. And we joined with the school to offer these services. Then they could also request services, and then there was an additional assessment done related to the services. If we turn to the next slide, this is actually reiterating one of the issues that Howard brought up in terms of disaster recovery. And you see on this slide in 2005-2006, over 45% of the students met cutoff for referral. And you see that it goes down, but then it goes up again with Hurricane Gustav. And then it goes down a little bit more, and it goes up a little bit more with the oil spill in 2010. And you can see that the current level is about 23%, and my understanding is by now it's supposed to be down around 10%. And we don't know the before figures. We don't know how high it was before in terms of reported symptoms, which is the case in a lot of disaster research. But at least in this area, there still seems to be a need for mental health services, and probably in most disaster areas. So just if we turn to the next slide, it's important to know that children of all ages are traumatized, and we all know that. And disaster literature helps us a lot in not only knowing risk, but also helping to determine how to give them the most support. A lot of children had direct traumatic experience before the hurricane and since the hurricane, and become then more vulnerable. We also know the amount of support from family, school, and community is very important, and previous trauma and loss, and all of these have contributed to the symptom patterns, and that's why the school's so important. If you go to the next slide, we not only provided services to the children, a lot of training for teachers, a lot of support services, continue to do that, consultation for school counselors and social workers, parent groups, and different kind of resilience building programs in the schools. The common symptoms that we saw in the children related to a sense of not only depression but hopelessness, the chronicity of the trauma and the aftermath, as well as anxiety, continuing anxiety. We're a little concerned with all of the press now on the 10th anniversary is going to raise people's anxiety. We noticed that we've talked about all the things that we're remembering that we didn't remember, but people, it's in the middle of hurricane season, and anxiety goes up. And with that, behavior and emotion dysregulation, which with the reminders is probably somewhat higher at this point. The primary mental health concerns on the next slide, children with previous trauma were more likely to show symptoms and be referred for services, and we found since then to children who experience additional traumas, certainly there have been a lot of stresses, domestic violence, substance use, other types of things, they're more likely to show mental health symptoms. So that essentially the chaos and deprivation of the environment contributes to increased symptoms and problems for these families. If we turn to the next slide, I just want to briefly talk about a program that actually NCTSN, many people within NCTSN, Melissa, Bob, and others consulted with us on, and that was called the St. Bernard Family Resilience Program, which essentially was a leadership program. We were very fortunate through the Department of Psychiatry to receive a major award for this program related to public-private partnership between community and a medical school. And essentially, this program addressed both educational and mental health needs of students by looking at different ways that they could achieve their potential. When the program was started, which was in the spring of 2006, there weren't many young people in the program. There weren't that many young people around. And the children that were chosen for the program then were not necessarily people you think as traditional leaders. In fact, one of them had dropped out of school, but essentially these very talented principals who no longer had schools to be principals of, and teachers, as well as our team, worked with them to help support their development and ways for them to become more resilient. If we turn to the next slide, not only were the young people in the program learning different aspects of leadership, but also the St. Bernard Family Resilience Program gave special attention to the alternative school, the Raleigh Alternative School. And some of the things they did, they helped plant flowers outside of this temporary high school that represented the 3 different colors of the 3 high schools that had been destroyed. They helped with the younger children in the preschool program in terms of supporting them, so the older children helping the younger children. They brought in programs related to drunk driving and how you shouldn't drive while you're drinking, and a lot of substance abuse programs. So a lot of different activities were part of the Family Resilience Program. If we turn to the next slide, this program, with a collaboration with LSU HSC, showed a way to build resilience and to support recovery from all of the kinds of things that you can see on that slide that they were experiencing. And in the program, one of the students asked his dad if it would be 5 years until they could go back to fishing, and the dad was very quiet and said, "No, son, it might be more like 15, and it made me feel very sad." And if we turn to the next slide, we'll see one of the projects that the children in the leadership program were doing, and that was replanting trees in the wetlands to try to help the environment. So a lot of different activities which were, and still are, enormously successful in terms of building resilience. So I just want to leave you with a few lessons learned related to children, because children are really important to pay attention to, and unfortunately with disasters, I think after Katrina and some of the other disasters and with the wonderful work of NCTSN, we have much better plans for children, but at that time, our plans weren't that good. But one of the things that's important for us to know is most children will be resilient, and how they'll be resilient is with support from adults. And so we need to support the adults as well as the children. And it's also very important to have supportive services in areas where children can access them, in schools, in preschools, in community centers. We've learned also in primary care facilities that in order to support children and families, we need to be out in the community where they are. Next slide. We certainly know that training on trauma in school settings and other settings is extremely important. Supports and services are also needed for the non-traditional first responders, the teachers and school personnel, and certainly for parents. And then preparedness is crucial. Our level of preparedness in this part of the country right now is, thanks to the work of Tony Spire and others, is incredibly incredibly better than it was at the time of Katrina. And not just the federal and state, but at the school level and community level. And finally, this is perhaps one of the most important things for us to think about, is to recognize the needs of all of those who provide support for volunteers, outreach workers, health and mental health, because of the risk of them experiencing PTSD or compassion fatigue. So in recovery, it's essential to emphasize the need for self-care. And with that, I will stop and thank my colleagues and here and in NCTSN, and I think we have some time for questions.
Absolutely. Thank you to everybody. I mean, I think what this presentation also shows that, you know, with a disaster becomes support of one another. And I know from speaking Bob and you all have become friends, and you know, supporting each other over the years, and seeing all the hard work, and to see now Tony working with you has really shown just how much in 10 years the level of work, the level of dedication, and I think that goes to one of our first questions, which really taps into first to you, Howard and Joy, you've kept your team together quite a lot in the last, almost fully. Now, how did you keep your team together, and what were some of the things that you did to take care of your team? And Tony, the same question. That was one of the parts to the Louisiana spirit. And for those that want to send in questions, I just want to remind you that you can send in questions by emailing us at question@nctsn.org. And again, that's question@nctsn.org. So Howard or Jory, would you like to start about what you did to support your team?
Yeah, I think that's a really important question, and the answer is multi-tiered. First of all, we had to find our team because, there wasn't very good planning. We didn't have smartphones at that point with area codes that were in a different area, so we had no telephones, no cell phone access, and no internet access because our whole internet went down at LSU and was down for quite a few months. So finding our team was really challenging. There were emergency lists that were put up by the medical school in different ways to access them on the overall web, but it was challenging to find our team, and it was sort of word of mouth and have you heard from someone and figuring out how to text and other kinds of things. But once we found much of our team and the people who were able to come back, the issue of how to support them was extremely important. When we talked about, our work on the boat, that was incredibly helpful for us, for our team, because we had a place to be, and we had a place to be together, and we had a place to talk and support each other, and that made a huge difference. But before that, there were some areas of the outside of the city where we found spaces to meet. And we would try to meet with the team once we had some access to the city or the outside of the city. Once a week, the meetings were supposed to start at 4 o'clock, and they generally didn't end till 7 because nobody wanted to leave. But it was really, really challenging to get our team together for the work that we were doing. And I know that Howard's, through psychiatry, did some heroic work with the team and for the psychiatric patients as well.
Right. And getting to that question, we also, it was actually one of our assistant business managers' homes, and then one of the psychologist's apartment, where we would somehow be able to get together. We also did some mind-body work with trying to help people with knowledge of how to unwind and deal with feelings, but we'd be able to talk and communicate. With the, as Joy said, with the members of the faculty and residents, we were able to keep up communication, and as I pointed out, even using the conference room at one of the human services districts in Baton Rouge, we're able to have tele-mental health, both teachings and conferences to be together. We did other things for other members of the team. For example, I remember when we were asked by the head of otorhinolaryngology to get together. It was going to be, in quotes, their grand rounds, and they did it in Baton Rouge at a restaurant, because one of their very valued faculty members had been stuck in Memorial Hospital, and some of the residents had been sent home, and we sat around and were able to talk for an hour and a half, and even the strengths that they had. And afterwards, we got a note saying this was the best conference they had had. But we managed to maintain communication, and using this and other ways of doing it, we're able to get people back together.
And Melissa, with Louisiana Spirit, there was a very specific, we had a workforce of 800 counselors, and many of these individuals were survivors of Katrina and had lost just about everything they had. there are three things that really think would be good for any program to consider who has to deal with a massive recovery effort. And one was we had specific stress management cadre that kind of lived their own life, visited with workers in the field, attended meetings, had meetings monthly with different groups where they just had fun. And people could share a camaraderie with each other of common experiences and tell jokes and have little skits and do things like that. So real innocent kind of ways of releasing pressure. We also asked that each location of main location and some satellite locations have a reflection and relaxation room or space where any staff person could go to 15 minutes, and we had aromatherapy, we had relaxing music. We really integrated and insisted on taking care of yourself as part of your job responsibility, and that one should have legitimate time to do that. I'll stop there.
Michelle, do you want to answer that in terms of the work that you did with the first responders?
Well, I appreciate, because I feel like Howard and Joy are being much too modest. I feel as part of the team that they kept together, that they led by example. They were always checking in to make sure that we were taking care of ourselves, that we were not overdoing. I cannot remember the number of times they asked me how well I was sleeping, if I was getting meals regularly, asked if I needed a break, that sort of thing. And, you know, when you get that sort of support from your supervisors, you take better care of yourself. You need to have it modeled from the top down. And so I think that was really pivotal. And having experienced that, then I could do that with my trainee. I had an intern who came back and worked with us on the ships, and I could model that with her. And I could talk with, I think, real authority to the first responders about the importance of modeling it for their trainees and that sort of thing, and also taking care of themselves.
Absolutely. And I know with the whole team, I remember with Louisiana Spirit, we actually did a study looking at even just some of the interventions that were integrated into Louisiana Spirit, how the workers were saying that not only was it important to learn the skills to work for the survivors, but it helped them themselves. That they had, most of the workers that, Tony, you mentioned of the 800 had been impacted in some way, whether they lost their own homes and were in trailers, that they were, had lost loved ones, or had significant hardships, and that they really highlighted that even some of the training that was brought into the program helped them to be more effective parents. They reported being able to help family members who were having difficulties, and then made them feel more competent in their jobs. So I think just to add to what you were saying, Tony, that there was the obvious stress management aspects that were added, but I also think sometimes some of the trainings and things that you brought in had positive outcomes that helped your workforce.
And thank you for mentioning that, Melissa, because that, in its various iterations of providing structure, also provided support. And that was really important. We'll talk more about that on webinar number 3.
Absolutely. I know another question, you guys had to make a lot of critical decisions very early on, and that there was being pulled in many directions. Kind of now that you're looking back and preparing for this talk, is there a lesson learned about something that, a decision that you made that is important for others to understand, or something that was key in terms of the long-term recovery?
Well, I'll start on that. Yes, there was. And once you got past the initial shock of what had happened to your communities, you realized a Band-Aid and a short-term fix was not going to happen, that this would be a decade-long recovery process. And it'll be longer than a decade. We know that now. That it was going to be a major shift in lifestyle and worldview for the communities. And so the lesson learned for us was the only way to build a successful recovery was engaging communities in their recovery and shifting our services and our interventions so it kept pace with the evolution of the community's recovery, and we were servants to the communities, always putting community and the people who live there first. And again, in our next webinar, we'll talk in more detail about the techniques to do that, but never losing sight that we were servants to the community.
One of the things that I think is very important that actually we learned here, we learned from the people here, we learned from our own experience here, and in terms of how we could even get our operations back going, continuing on and working with our team. I mean, we didn't have office space for 4 years, and then it was still under construction for years after that, is being able to do your work and being able to serve communities and serve people in an environment that we considered a new normal, that things were different, and they're going to be different for families and children and community and all of us, and being able to adjust to the new normal and be able to move forward with that. And I know when we consulted after this earthquake, tsunami, and nuclear disaster in Japan, that was something that was extremely helpful for them to think about too, and realize that it's extremely important when you're going to have experience a major disaster for the community and individual at all levels, for the families, for the individuals, for the community, for the administrative people, and all this. There's going to be a new normal that we need to adjust to.
I would think another, I'm just trying to add a few, there's an unevenness in the recovery for different communities, and being able to respect that and realize some of the factors influencing that. Just as it's important that we could learn that people could exhibit resilience while at the same time they were having mental health symptoms, that both could be present. And we could see very normal patterns of resilience in most people. And also to be careful that we're not pejorative, that people who are recovering in different ways or who are having symptoms, to respect where they're coming from, and to try and be available. And just as Joy was saying, as we all learned new environments that we were living in and new norms, that one respects so much the people's sense of place and the importance of their communities, their importance of their ways of life, and to realize that we are assisting them and in everything that we do.
Yeah, I think the only thing I can add would be the importance of the prior relationship. I think that if we had not had the prior relationships in place with the first responders, we would not have had as easy a time getting entree to do and permissions to do the kind of work we did. It really underscored for me the importance of developing good working relationships and collaborations within the community and within receiving communities, but also maintaining those and really treasuring those, because this really is a shared recovery, and there is no one part of the community affected. And when I say community, I'm really thinking across states, of the whole Gulf region that was affected. There is no one part of us that is recovering without the assistance of other parts of it. And there's not even the Gulf region by itself recovering without the assistance of the rest of the country. And so those relationships are so incredibly important in terms of building, maintaining, preserving, and treasuring.
I want to thank everybody for the presentation, and we know these kind of talks act as a reminder. I think we're all thinking about where we were 10 years ago and where we are now, and all of you have inspired each one of us, and I know there was so much to discuss, and there's many aspects that we probably have not been able to bring up today, and hopefully some of the other talks will help to round out some of the aspects of what we've learned and what we've done after Katrina. We wanted to make sure that the presenters had enough time, and so we're actually going to record a podcast and put it on our Learning Center for Dr. Pinus to reflect on what was said today. We wanted to make sure that there was enough time and space for the discussion. So we will have that on our website, and we can make sure that there's a notification of that. I also wanted to alert you that our second webinar is scheduled for September 3rd at 10 o'clock in the morning Pacific Coast time, and that is a case study of post-Hurricane Katrina reconstruction. It's on Project Florida Lead, a decade of trauma-informed programming in New Orleans area schools. And the final webinar is scheduled for September 9th at 12 noon Pacific Coast time, and that's really looking at with all those that were displaced, what were some of the lessons learned and supports that were provided throughout the United States. And we will have representatives from Colorado, again from Louisiana, from Houston, and also from SAMHSA, who can highlight the extensive work that was done from a federal level. Bob, any last words before we wrap up?
No, I thank you all. They were very both moving, and I said it not only reminded for Katrina, but lots of people have had other things happen from other storms and hurricanes and other events that this can serve a reminder of as well. So respectful of all those range of responses, and I think the comment in the program earlier that that mental health doesn't always look like mental health services. You can see that being a mental health provider under these circumstances is really looking at a much wider framework of assistance that really preserves the family and the schools and the community and the rebuilding that goes beyond just what we might consider an individual mental health service. And I think all four of our presenters really illustrated that over the long term of the work that they help provide for Louisiana and beyond.
So with that, thank you, everybody.